Where can you find comprehensive medical services, expert clinicians, newly renovated spaces, and a breathtaking view all in one location? Only at the Des Moines University Clinic. Call today or visit dmu.edu/clinic.
Hello, I am Dr. Carrie Smith, and I'm a physical therapist in the Department of Physical Therapy. And today we're going to be talking about the central control of the core and bladder function. So to begin with a little about myself, I said that I work in the Department of Physical Therapy, and I also have a clinical practice in pelvic health at the Des Moines University Clinic. I'm the clinic manager, and I love to do community education, especially on the pelvic floor, which many people don't have a lot of background knowledge about how to keep it strong and the normal functions of this essential organ. And I'm also a very proud alumni, along with my husband Kevin, and here is our family of 3 boys. So one of the central themes as we start learning about aging and just keeping strong is we talk about control. We want to have control of our balance, we need to have our strength and mobility, but we also want to have bladder control. That is certainly an essential function that we all want to maintain with our aging process. So let's start off. What are your perceptions? What are your perceptions as far as, is urinary incontinence a normal part of aging? Do you feel like nothing can be done to improve bladder function in older adults? And would you seek treatment if it did not involve surgery or medications? Hopefully through this presentation, we might be able to provide a little education and possibly change your perceptions on the bladder function. So let's talk about normal bladder control. Again, do you take your time going to the bathroom after you awaken in the morning? Do you go to the bathroom during the day when you want? How about being able to sit through a meeting, movie, or road trip without thinking about your bladder? Do you sleep through the night or wake up only once to urinate? How about the sensation of having to pee? Does that cause anxiety for you? And you should have no leaking at any time, even after you've had a baby, even if you're doing a jumping jack, even if you've had surgery. Those are all things that I've listed here are things that we can hope to have as normal bladder control. Now, for many people, we have a weakness and we might have leakage, and we'll talk about that today. But the thing is that it can be corrected, and many people are just not aware of those as treatment options. So who is affected? This is a picture, as you can see. There's children, there's teenagers, there's active athletes, there's younger, older, there's grandparents, there's new moms, there's middle-aged. So I hope you get the idea that it can impact any of us. So what are bladder control problems? First, we might have leakage. There might be a urinary urgency and frequency that we just can't control, or that it interrupts your lifestyle. Maybe it's incomplete emptying, that after you go, you just still feel like you have to empty some more. Or nocturia is like when you have to go at night. Or maybe there's retention. Those are all bladder control problems that we also treat in physical therapy, bowel incontinence, constipation, pelvic pain. All of those can be a part of your pelvic floor problems. So urinary incontinence. Just a few definitions. It is defined as any involuntary leakage of urine. It doesn't mean that you're continent unless you do these activities or you've had these different these things in your history. Incontinence is any voluntary leakage of urine. So there's a couple of different types that we're going to talk about. Stress urinary incontinence is when that involuntary leakage occurs with activities. So it can be running, jumping, could be coughing, sneezing, picking up a grandchild. So really it's due to any increase in abdominal pressure that's relative to the urethra. So the urethra cannot handle the additional pressure that's pushing down on it, and you leak. And then there's urge urinary incontinence. And that just happens with a sudden, unexpected urge to urinate with an uncontrolled loss. So maybe this is a situation that you've experienced. You are driving into your car, you park in the garage, and you're getting out, and all of a sudden you just have to go. You can hardly get the door unlocked. You can hardly get to the bathroom and get your pants undone, and you just have this immediate urge to go. That's the urge urinary incontinence. And most people have a mixed. It's just kind of a little bit of a combination of both. So let's start off, just like with any anatomy presentation or any medical presentation, we bring out the anatomy. So if we want to look at this is a side view. And so just to kind of orientate you, so here's your spine. You've got your bowel, your uterus, as this is a female, and your bladder. So with that, some of the things that we're going to be talking about with that bladder are that as you're trying to go, right here is a little sphincter, and that's at the tip of the bladder that's just kind of holding it closed. And so as that is closing, then the bladder continues to fill with urine, and the pelvic floor muscles continue to contract. And then when the bladder decides to go, it contracts, this part opens up, and the pelvic floor relaxes so that you can eliminate. We also talk a lot about with incontinence. We're not going to have time to talk about it today, but we always ask a lot about your gynecological history and if you have any constipation issues. As you can see, the close proximity to all these organs, if you have problems with one, it can definitely impact another. Here's another look at our pelvic floor. So this is kind of like the bird's eye view looking down. To orientate you again, here's the pubic bone in front and your spine in the back, and then you have your urethra, the vaginal opening, and the rectum. So as we're looking down there, you can see that these pelvic muscles kind of sling around all of those openings to provide support. And then you have the deeper muscles back through here that also provide some support and stability. So you can kind of see that when you're contracting these muscles, you're going to have kind of a squeeze, and it's going to close those openings and then kind of lift that urethra, vagina, and external anal sphincter up in towards your body. Towards the end, we'll practice some of the exercises, but this is kind of something you can reflect on as far as knowing how the pelvic floor anatomy all works. So let's talk more about bladder control. There's always that question of how does this all really work? Well, we know that the blood filters and returns to the bloodstream about 200 quarts of fluid a day. And within that 200 quarts, we have 2 quarts that are kind of pulled off in the form of urine, and they need to be removed from the body daily. So the rest of that fluid continues to circulate through our bodies. And so this is an interesting fact that only 15 drops of urine per minute are stored in the bladder. So if you're a person that thinks that you need to completely go to the bathroom every 30 minutes because you drank a lot this morning, it's like it's really not. It does happen. If you're a higher drinker, you're probably going to have an increased frequency. But suddenly the kidneys can't just circulate and filter out all that urine. So really our bodies can store and our bladders can store a lot more if we can retrain them. We start to get the first sensation to void at 150 milliliters to 200. So that's what is represented here. A very small amount. But our bladder can store up to 400 to 600 milliliters of urine. And this is 500 milliliters here. So you can see there's a large difference in that. So really, when you get that first sensation to void here, if you're drinking a lot in the morning, you can store a lot more. So I encourage you, don't go to the bathroom just in case all the time. So with the postponement of voiding, so what happens is the nerve signals to the bladder, actually goes up to this sacral micturition center, and it tells the bladder that it can't contract yet. It's still filling up. So this bladder is just filling up with more and more urine, and it's providing a little bit of a stretch. And so then that's sending the signal up to the brain, and the brain sends a signal right back down to it, says you can't contract, you can't go yet. And so with that, it tells the bladder that it better continue to contract right here at that trigrone, and so that it must continue to fill. Once So the outlet pressure, so this pressure right here from the pelvic floor muscles contracting is tighter than the pressure up here. So as the pelvic floor muscles are contracting, this must stay closed and continue to fill. Then, with bladder emptying, those stretch receptors send that message up to the brain, and the brain says, okay, you're pretty full here, it's starting to get uncomfortable. So then the brain cues you to start moving to the bathroom, and hopefully you have enough control that you can sit down, remove your clothes, sit down, and then once you're sitting on the toilet, and remember, you're sitting on the toilet. It's not good to be hovering over top of it because your pelvic floor muscles can't relax. So once you relax, then the sphincters at the top of the bladder relax, and then the muscle contracts. That bladder's a muscle, and it contracts, and it empties out all of the urine. Well, all but about 30 to 100 milliliters in just one continuous stream. Sometimes as we age, we start to hold a little bit more, like that, closer to 100, and so that might be something that your doctor tests to see if you're having recurrent infections that maybe you're just not completely emptying. So that's something that does happen. So let's talk about some changes with aging. That's kind of the normal process. But some of the things that happen with aging is that upper urinary tract has a decreased ability of those kidney cells to filter blood and concentrate urine during the day. So that means during the night, you're going to be filtering a lot more, and that's why it is normal for people over 65 to have to go to the bathroom 1 to 2 times at night. Under 65, 0 to 1 time is normal. There's also a delayed sense of that urge. Sometimes you're not getting that sensation of that occurs at like 150 milliliters. Sometimes you just don't really feel it until it gets a little bit more full. Changes in aging also occur with fluid intake. Many times when we start having bladder problems, we restrict our fluids. With that, where the thought process is that if I'm not drinking as much, I won't have to go to the bathroom as much. Unfortunately, it also is concentrating your urine a lot more, and sometimes that can cause problems because the bladder gets irritated and it just wants to get it out. There's also some changes that occur with the bladder is that these, the lining here can kind of have, it's a muscle, and it can kind of have just some random sporadic overactivity, little twitches or little spasms, and for the most part we don't really even feel it. But with aging, we start having more of those occurrences. There's also a smaller amount that's actually voided. We kind of spoke about that earlier, that sometimes you start maintaining just a little bit more fluid within there, and then it eventually leads to a smaller bladder capacity. And last, but not, and then in men, you have a large prostate. So if this was the male picture, you would have a little bit of an enlargement here of that prostate gland that tends to get larger with age, and so then there's more restriction in that urethra. In women, they have more hormonal changes. So within that urethra, it has a thin mucosal tissue that kind of collapses on each other. So think of it like a straw, and it has some sticky material that kind of collapses in its mucosal adaptation and secretes mucus to enhance that closure. But when you're lacking estrogen, it's like that, just stays open, so it's just like an open straw. So that might be why you kind of leak and you didn't even know it was going to happen. However, those things are sensitive to hormone, and some people will choose to do a little hormone replacement in speaking with their doctor. So talking about epidemiology, I'm just kind of reviewing some of this information so that you can realize that you're not alone if this is happening to you. So by looking at many different studies, older women, 34% have any urinary incontinence, and 12% have daily urinary incontinence. In the middle-aged and younger population, it was 25%. So if you think about it, that's 1 in 4 people. So think about all of the women and the friends that you know. It kind of makes you think that at least 1 or 2 of you within a small group is probably having incontinence, but it's just not talked about. It is more common to have stress incontinence in the younger women with the increase in activity and pressure, And then as we get older, it's more of kind of that urge and mixed incontinence. And for those males that might be watching, I also want to let you know that you might have lower incontinence in the earlier in your life, but as you age, the incontinence rates for men significantly increase, especially after having a prostatectomy or other prostate related procedures. So some of the risk factors include possibly just pelvic floor weakness. Because you don't work the muscle, it's going to get weak. Prolapse, or there's some tissue that's falling into the vaginal canal. There might be nerve damage from surgery or birth trauma, sphincter damage, or maybe even some neurological disorders that are causing that. Medications can have a contributing effect, along with the increase in age, and whenever we have a decrease in cognitive function, impaired mobility, or increase in weight. So the thing is that the populations have definitely increased, and they predicted a significant increase in these conditions just with our aging population. So you can see how prevalent these conditions are, and that's just urinary incontinence, fecal incontinence, and the pelvic organ prolapse. So that is an increase from 28 million to 43 million people per day that are impacted by incontinence. So no wonder that we're pretty busy in the clinic helping a lot of people out. So let's talk about normal bladder patterns. This is kind of interesting information that you should urinate every 3 to 4 hours, or about 5 to 8 times a day. The average time interval is between 2 to 5 hours. So the younger population can hold it for 3 to 4 hours, and in the older population, we try to get them to go at least every 2 hours, kind of on a timed voiding, because if they're not getting that first little message or that first sensation that they have to go, then suddenly they have a full bladder and they sneeze, or they have to run to the bathroom and they can't control it, then they have the accident. So if we go on a more frequent basis, usually that can also control it. Talking about hydration, urine should be light yellow, and the urine stream, if you should count it, should last 10 to 15 seconds. The total number of nighttime voids I kind of went over earlier. And the amount of voiding is usually the first one in the morning is the longest, of 8 to 12 ounces, and then common daily void throughout the day is 6 to 10. But there's also some impacts of hydration and the food. I had mentioned that some of the different, the bladders do not like to be having concentrated urine in it, and that can be a bladder irritant, actually make you want to go more. However, if you drink over 100 ounces of fluid, it might be associated with an increase in incontinence because you just can't handle that much fluid. There's some food irritants for our bladder also. And in the always category are caffeine, alcohol, coffee, regardless if it is decaf or not, the tannins in it make it an irritant, chocolate, and smoking. And on an individual basis, sometimes people are more irritated by citrus, tomato, artificial sweeteners, and carbonation of any kind, even if it's carbonated water, spicy food, milk, and sugar. Now those are like I said, sometimes it does not bother everybody. The other thing is we want to make sure you eat plenty of natural fiber, because constipation causes straining on those pelvic floor muscles, and if we have constipation, it's definitely going to impact and push on the bladder and cause us problems that way too. So it's time to kind of start thinking about these pelvic floor exercises. Hopefully you have an idea of what your normal pattern of bladder habits are, and maybe we should start working on some exercises to continue to strengthen it. If you don't have any problems, that's awesome. We want you to continue to be healthy and well, and so I would also encourage you to start thinking about doing some of these Kegels on a regular basis. So first, to start thinking about visualizing those muscles. It's kind of a hammock from front to back, and you can kind of thinking about squeezing around that urethra, maybe squeezing a little bit at the anus and lifting it up and towards your body. If you're sitting, you might want to sit up nice and tall. Sometimes we'll even kind of say like you're going to sit right on that perineum, or sitting up nice and tall so you're sitting right on your vagina. And then if you contract, you can kind of feel it lift up and away from the mat or the chair, And if you cough, you might even feel that perineum kind of touching and kind of pushing down into the chair. It's okay to look at your body, and maybe you need to see those muscles in order to get a better idea of feeling them contract. And then I want to encourage you to always contract with using that diaphragmatic breath. So you're going to contract as you exhale, and that's going to facilitate a deeper contraction from your abdominals, your diaphragm, and the pelvic floor. So we're going to take this into a few exercises. These are called Kegal exercises. So once again, it's kind of a squeeze and lift of the pelvic floor. There should be no movement of the stomach or buttocks. And you're going to try to perform 30 to 80 of those contractions a day. Not all at one time, but more kind of throughout the day. You're going to try to incorporate that. But really do quality contractions. So think about those muscles and try to really feel what those muscles are doing and contracting. You also want to do quick contractions. Just like when you cough or sneeze, that muscle needs to quickly contract and give you support. But then you also need to do longer contractions, like holding it for up to 10 seconds. If you can hold it that long, you might need to start at 3 to 5 seconds and then progress as you get stronger. That's just to kind of build up the general everyday strength of those muscles because they're working all day for you. Another reminder is to completely relax between the contractions. We don't want to contribute to some other problems that might be caused from high tone. And that's a whole nother little education session, is to talk about if we have too much tone, we have constipation, pelvic pain, pain with sexual dysfunction, those types of things. So definitely contract and squeeze up as high as you can and relax and let it go all the way down to a relaxed state. A couple other thoughts that you can think about is you're going to squeeze your pelvic floor before you sneeze. Kind of give it a little support before you have that intra-abdominal pressure pushing down and giving yourself a chance to hold that. And if you're doing a lot of lifting, like maybe your groceries, your laundry bag, or your children, think about exhaling and contracting your pelvic floor abdominals before you lift, or even before a sit to stand. You can start incorporating that activity into your daily functional tasks. So here's a few other exercises that you could try on your own. You could be doing Kegels in bed, sitting, standing, any position where you'd want to continue to strengthen that muscle. We definitely have to focus on that isolated muscle if that's what we want to strengthen. Just like we wouldn't do a bicep curl in order to strengthen our pelvic floor, you need to think about it and to try to activate the right muscle. Now, the one problem with doing the presentation and not really having you here to show you how to do these is that we know through research that half the people that are just told to do exercises, just like I'm doing here, don't have a clue how to do them, and they're trying and they're being unsuccessful. So if you're trying these exercises at home for a couple of weeks and not having any changes, then make sure you go see a physical therapist to teach you how to do these correctly. And a pelvic physical therapist one specializes and has advanced training in doing the evaluation for this. So you're going to also maybe do a Kegel while you're seated and with coughing. So just seated, you're going to contract those muscles and then do a little cough and try to hold that. You might do a bridge and incorporate that pelvic floor control as you're bridging up. Or maybe it's a standard plank just against the countertop and you're squeezing your legs tight, pulling your belly button in and squeezing the pelvic floor at the same time. And again, we talked about that transition from sit to stand with including that pelvic floor. So just to motivate you a little bit more would be to talk about the cost of treatment for incontinence. And these are almost 20 years old, but the annual direct cost for women was $12.4 billion, and that's talking about 70% of the cost was from absorbent products like your Poise and your Depends. 14% of nursing home admissions, because if people are incontinent at home, the families just can't take care of them when they start becoming incontinent of bowel and bladder. And then 9% from treatment. Within that treatment cost, a lot of it is just from surgery. And then some people have complications and then just the cost of the diagnostic and evaluations. So you can see actually coming to physical therapy, even if it's for 4 to 6 visits, is going to be a very minimal cost in comparison to having a lifetime of absorbent products. So the annual direct cost per individual typically with incontinence is $250 to $900. Basically, it depends upon how many absorbent products you're using per day. And then you have to think about the indirect cost of missed work productivity, especially if you have dysfunctional voiding patterns and you're going to the bathroom real frequently. It's a lot of missed time away from your desk. We also want to talk about that sequela of urinary incontinence. Many people stay home more frequently and they decrease their social activities. They have decreased physical activity because they don't want to leak during that. It leads to deconditioning and an increase in falls as people are rushing to the bathroom, and increased depression. I will have to say that I would rather have you stay active, socially engaged, and do your physical activities. And sometimes we just have to use the old saying of you have to pad up and play on. But we can continue to work on becoming more continent and still keeping you active. So that concludes the presentation. If you have any questions, you can sure reach me in the clinic, or that's my email. If you have direct questions, I'd be glad to answer them. And I hope that you have learned a little bit more about the normal bladder control, and I hope that you continue to stay healthy and well and stay safe. At Des Moines University Clinic Physical Therapy, our providers are experts in movement and improving your overall health and function. We pride ourselves in focusing on the whole person and develop rehabilitation programs that address the psychological, social, and physical aspects of your pain and functional impairment. Our state-of-the-art facility includes private treatment rooms for your privacy and comfort. The technology utilized by the expert clinicians facilitate the outcomes of the rehabilitation program. We provide general orthopedic rehabilitation following surgery or injury, along with the treatment of aches and pains that occur from aging or living an active lifestyle. We have therapists that have advanced training and specialty clinics for vestibular, balance, and concussion recovery. We also treat many neurological conditions, like the recovery from a stroke or Parkinson's disease. We have specialty training in the management of persistent pain conditions and strive to improve the quality of life and to keep you moving. Another specialty clinic is working with men, women, and children that have pelvic floor problems with incontinence or leakage of bowel and bladder, constipation, pelvic pain, perinatal care, or the recovery from cancer or pelvic surgery. Although many individuals may not need rehabilitation, they can benefit from a wellness assessment to help improve movement that will reduce the risk of injury and improve general wellness. The physical therapy wellness exam is designed for all ages as an assessment of an individual's flexibility, strength, walking, balance, and aerobic conditioning.